to our final session of TB 101 series.
All right, my name is Jonathan Wortham, and I'm a medical officer in the Division of TB Elimination at CDC.
And my name is Miriam Haddad, and I'm a nurse epidemiologist who works here as well.
And we're going to talk to you a little bit today about TB outbreak detection and response. And we're really hoping that this can be an interactive session, so feel free to put questions and comments in the chat, and we're happy to engage with you as the session goes on. And so just a quick review that this is based on the self-study modules in modules 8 and 9 in the core curriculum. Don't worry, we're not just going to regurgitate the material, but we're hoping to engage with you interactively as we go through these concepts.
And speaking of that, could you switch it so we can see the chat? Perfect. Thanks.
And so first, we'll discuss the natural history of tuberculosis and how to break the chains of transmission. And so tuberculosis transmission starts when someone with infectious TB or TB in the lungs, airway, or larynx is exposed to somebody who we term as a contact. There's a couple of ways that we stop transmission of M. tuberculosis. First is to find and treat people with TB disease. And hopefully we can promptly do that because effective treatment rapidly reduces infectiousness. In addition, we implement infection control precautions to prevent exposures to infectious TB. Another way that we stop M. tuberculosis transmission is through timely and thorough contact investigations. And the point of contact investigations is to identify those people or contacts who are exposed to people with infectious TB. Second is to assess the contacts for infection, TB infection and TB disease. And third, provide the appropriate treatment, whether that's for an infection or disease. And so now we'll discuss how contact investigations prevent TB outbreaks.
And I know you spoke last week with Mark Wellman from Newark about how to do contact investigations. So that's like the perfect segue to this outbreak talk. When I think about a contact investigation, I have this mental visual that the case, which we've depicted here as the person in blue in the middle of the diagram. And I will say I'm using the word case to describe a human being with tuberculosis disease as shorthand, but of course I wouldn't want to use that sort of stigmatizing language if I were speaking directly with somebody. So the person with TB disease that, like Jonathan described, we've determined was infectious because it was in the airways and being expelled when the person spoke or coughed or sang, has exposed contacts, right? And so they're shown in that ring around the case in the green or teal color. So that little starburst is how I mentally think about a contact investigation, and that's how most contact investigations are organized, with this kind of one case, multiple contacts approach. And then Jonathan, if you don't mind going to the next slide. Okay, this is going to be familiar to a lot of you if you do contact investigations in your daily work, but it's always helpful, I think, to stop and think about infectious periods in case that's not something all of you have thought about. But when you start interviewing someone who's recently been diagnosed with TB, it's super important to estimate how long they've been infectious, because that can make a big difference about who to consider in or out of the contact investigation, especially if the person's been like in a school setting or a hospital setting. So the very first question is to determine whether they've had any symptoms. And if they have, try to get as close to a date of the beginning of those symptoms as possible, because based on those 2005 guidelines, you're going to go back 3 months from the start of those symptoms. And that's regardless of whether they were smear negative, smear positive, cavitary. You're going to use the start of the symptoms and go back 3 months. And that is, like I said, what's in the guidelines as your very conservative start of your infectious period. But if the person says they don't have any symptoms, they really were kind of surprised by this TB diagnosis, then you're going to want to go by some of those clinical findings if their sputum was positive for acid-fast bacilli, or if on radiography there's evidence of a cavity in their lungs, then you also want to go back 3 months. But instead of going back from the beginning of the symptoms, you'd go back from the beginning of that first finding. And then finally, only for the people with no symptoms, no AFB, positive smears, no cavities in their lungs. With them, you can go back just 1 month before that first finding. And you probably went over last week, and I apologize, I couldn't catch the presentation live and it's not been posted yet. Some health departments, depending on resources, may not even do a contact investigation for people in that final category. But if you were to, you do need to go back 1 month. And then there's 2 concepts Jonathan talked about that you want your, yeah, you can go on, sorry, Jonathan. You want your contact investigations to be both timely and thorough. And the timeliness piece here is super important because you're not just looking for LTBI, latent TB infection among the contacts. Some of them might very well have TB disease. And I'll let Jonathan, since he's the pediatrician, talk about why this is especially a concern with pediatric contacts.
Yeah, so pediatric contacts in young children, they are really at risk of getting TB disease after primary infection. Especially young children under 1 year old, they're at risk of getting TB meningitis and other forms of disseminated TB. And so that's one reason timely contact investigations are really important, because you find people, especially young children, people living with HIV, the people who are at risk for complications and TB-associated morbidity, and get them on the appropriate treatment as fast as possible. The other pro tip about contact investigation that Miriam alluded to is, and is on this slide, you expect approximately 1% of TB contacts to have TB disease during the investigation. If you have 5 or 10% of people have TB disease, that's a tip that this outbreak, there may be other sort of places where the investigation needs to go. And so doing that timely investigation and figuring that out, that'll give you a sense of, a rough sense of where your investigation is and where it needs to go. So I think both of those reasons are really important. First, finding those people who are going to experience early and more severe morbidity, but also as a check to see, is this situation, are you close to that 1%? But if you're far away and exceeding that 1%, that means this investigation, and that means there might be a lot of transmission, or the pool of people that you're investigating is too small.
And in fact, unfortunately, we're speaking from experience because this year we've been involved in several large outbreak investigations where it was the children who were the tip-off that there was a problem. There were a lot of kids with clinical TB early in the investigation. But, you know, we often don't think about pregnancy enough as being a risk factor, and also recent pregnancy for postpartum women. Also, that 15 to 25-year-old age group, there's something going on with adolescents and young adults biologically that predisposes them, just like babies, not to the same extent as babies, to rapidly progress to having TB when they're recently infected. And unfortunately, those are also the groups who tend to be the most social, with a group of contacts beyond the house that you may not think of in your initial interview. And then, of course, we're already sensitized to be thinking about contacts with medical comorbidities. Does anybody want to jump in and mention anything about this before we go to the next slide? We can keep this conversation going for sure. We don't have that many slides in total, so please do feel free to pause and not just wait until the end to have conversation. And you can also use the chat.
Sorry, feel free to use the, sorry, Miriam, feel free to use the chat to comment or say anything.
The chat, we're looking at the chat box, but right now it's completely empty as far as we can tell, right?
Yeah, that's correct.
Okay. But you're also welcome if you want to come off mute and talk. Anybody's welcome to do that, although do know it's being recorded, so That might be intimidating. All right, so the other piece of contact investigations. Oh, so Katie, hey Katie, yes. Unfortunately in Minnesota, Katie experienced this several years ago. Lots of 15 to 25-year-olds with cavitary TB in that outbreak.
And one other thing that I think can be people in the sometimes in teenage and young 20s is these people can have sort of clinical findings of advanced disease and infectiousness like cavitary disease and sputum smear positivity. But sometimes due to reserves and due to that they're otherwise young, healthy people, they can
that's
they
true.
feel really
They
well.
keep going to work.
And so they
Yeah.
can have lots and lots of contacts at school and work. And so it can actually be, from a public health standpoint, those situations can actually be more challenging than people who are really sick with TB and too sick to go and have lots of contacts. And so it's definitely something in our experience that you'll want to be aware of.
Oh, great. And you saw, we're definitely planning to share these slides. Most of this comes from that module 8 and 9 and the self-study. But yes, we'll have the slides as well. And the reason that thorough contact investigations are so important, not just the household, but beyond the household, is that, I mean, it seems like such a logical thing to say, but it's a great reminder. Everyone with TB disease started out as someone's contact. Now they might have been a missed contact, but they were at some point someone's contact. And so the better you can do the contact investigation on the front end, the more you can save yourself work and hopefully a lot of transmission and morbidity on the later side of things. But for sure, it's within those first 2 years that you're really most at risk for progressing to TB disease if you were infected and you weren't treated. And let's look at this point Kristen just made.
So it looks like in the chat, Kristen is saying we have an asymptomatic patient with a chest X-ray clinically suggestive of active and so far AFB negative. Patient originated as a contact 2 years ago. This patient is in their 20s and was only discovered on TB screening for employment. Based on what you stated, would this be a contact tracing of 1 month prior to the chest X-ray?
I would defer to whatever your state TB program has as their guidance, or if you're in a county or jurisdiction where there's local authority who's already made that decision. So much of this depends on resources. The 2005 guidelines from CDC for contact investigations do give you latitude not to have to do a contact investigation if it's a smear negative non-cavitary case. But we do know that isn't a guarantee there wasn't transmission from that person. We definitely see transmission from smear negative non-cavitary cases. So that might be a situation where you might want to start out by looking at some of the closest contacts and see whether there was evidence of transmission and then make a decision based on that.
But assuming that the 100% agree with what Miriam said as far as working with your local public health authority, but assuming a patient who's asymptomatic, who you have one clinical finding suggestive of TB disease, sputum smear negative, that would be consistent with the 2005 MMWR. But there are sort of resource considerations and other considerations that you'll want to consider along with your local health authority.
Sorry to give it depends answer.
Okay, another question popped up. Does this progression to TB disease over the next 2 years represent 10% of the peoples who may convert?
In the old days, so this is like early 90s. So I was alive, it's not that old, but we had you've probably heard that rule of thumb that if you're infected, you have a 5% lifetime risk of progression, but that risk is higher, and that's where the 10% often comes up. It's a 10% risk in the first 2 years. All other things being equal, no HIV or other things. I don't know. It's so hard to say because all of that was based on 1990s. You know, there was HIV co-infection going on. We weren't using the same regimens we use today for LTBI. But what's safe to say is that once you pass 2, and if you want to be really conservative, 3 years past that initial infection, your risk does seem to plummet in terms of progression to active TB. I mean, that's why 1 out of 4 people on this planet is walking around with LTBI. And thank goodness, not all of them will progress to TB disease. Most of them will die with that latent TB still asleep in their bodies. But you've always got that risk for the rest of your life, unless you treat the LTBI for sure, that it could reactivate.
Yeah, and I think one of the things clinically, I know it's challenging to get to even identify and diagnose people with an asymptomatic condition, and getting them to take medicine can sometimes be, and certainly in my experience, a good discussion. But one way, maybe potentially, that I've had some success with in my dealings, is to talk about these regimens are 90% effective at stopping progression to TB disease. So whether that means for an individual, for certain patients, it may mean there's a 90% chance if you take this regimen that you won't have to experience any of the coughing and any of the side effects with TB. Other groups of patients, sometimes it's more important for them. You won't get to experience any of those effects for TB for you, but there's less chance you'll transmit it to the people you live with.
The people you love.
And so in certain cultural contexts, one versus the other may be the difference maker. But those are 2 sort of.
And the third is talking about the number of medications involved, right? So,
Exactly.
you know, we can cure disease, no doubt about it, just like we can cure LTBI. But you have to use a lot more medications. It's a lot less pleasant if you want to roll the dice and wait for it to reactivate.
Okay. Now we'll move on to why TB outbreaks occur. So in our experience, there's really 2 common elements to certainly the outbreaks we've been consulted on and the ones that people talk to us about. Those are long infectious periods, and so people who weren't diagnosed with TB, and that happens for a couple of different reasons, as well as people who are termed, we'll use the term vulnerable contacts, but that really means various different people would fall into that group. And sometimes and oftentimes, a lot of transmission has already occurred before the first indications to public health departments that there's an issue.
And I would just like to say, as a caveat to that previous slide where we said contact investigations prevent outbreaks, this is a situation where the health department is not to blame. You didn't fail with your contact investigation because you had no opportunity to intervene earlier in the infectious period if the person has a very delayed diagnosis, if that makes sense. Go ahead. Sorry.
Exactly. And this is why, like, I think that, you know, when we get consulted, we're never talking about the health department didn't do this.
Yes.
Because most of the time, these are sort of issues inherent to diagnosis and treatment of TB. And if we could solve those issues, we could solve the TB pandemic. And so these never hesitate to reach out to us, your state health departments, people like that. They can help, and they're not going to judge you for it. But basically, those long infectious periods kind of have a couple of different threads. And one of those is social risk factors, and so delays in seeking care for TB symptoms. So sometimes patients don't have access to medical care. Sometimes there's some disincentives. For example, we've seen situations where patients, for example, incarcerated patients, they theoretically have access to care, but they're charged what would be a nominal fee to people who are, you know, out working jobs, but sometimes it represents a very big proportion of the wages they get paid for the work that they do while they're incarcerated. And so even though they're coughing, this represents a disincentive to seeking care for TB symptoms, which leads to being contagious for longer, which leads to a setup for an outbreak. Another thing is healthcare providers unfamiliar with TB. And as TB incidence has declined in this country, many healthcare providers have not seen or taken care of a patient with TB. And so because TB has a lot of different symptoms that are pretty nonspecific and overlap with a lot of other clinical entities, such as community-acquired pneumonia, there can be delays in diagnosis. And while those patients are not being treated for TB, they continue to be contagious, and transmission continues to occur. And so these two sort of delays in seeking care and delays in diagnosis are really two common themes that we see in outbreaks.
And those lead to those long infectious periods.
In addition, we see people who we use the term vulnerable contacts. And that falls in a couple of different sort of groups. So people with pregnancy, there is something about, especially late pregnancy and early postpartum period, where there's something about the immune system predisposes to progression to TB disease. And so we've seen that we've seen that be a risk factor in outbreaks. In addition, exposure to people living with HIV is a medical comorbidity. We've seen a relatively recent outbreak where it occurred amongst people experiencing homelessness, so people in a congregate setting who are really close together, and with an increased incidence of HIV infection, which, as you know, confers increased risk for progression to TB disease. And so when you have people with long infectious periods exposed to those people with those medical risk factors, that sets you up for an outbreak. In addition, children. So children, you want to kind of think of, especially young children, as having similar risk to progression as people living with HIV. It's not exact, but it's how I thought about it. It's how I still think about it in a rough sense. And so whenever you have a situation with children who are at increased risk of getting disease after primary infection, and you have people with long infectious periods, you want to be concerned about an outbreak situation. And then, as we've also alluded to when I was talking about those other outbreaks, prolonged and repeated exposures in congregate settings. And those can be really challenging because of the decreased air circulation that sometimes happens with those environments. But also it can make the contact investigations much more challenging because people can't or don't know who they might have been exposed to as well.
Especially if there's people in and out. And we have Patricia asked a question.
Yes, we refer positive QFTs, job candidates, to their PCPs, primary care providers, for evaluation to rule out active TB. Very few of them return with more knowledge of their LTBI status. Instead, they are still convinced it is due to BCG. This is an excellent question.
Yeah.
And I think potentially this is actually evidence of some of the some healthcare providers who might be unfamiliar with TB. So as you know, there's two tests. There's two families of tests for TB infection. One is the TB skin test, and the other is the interferon gamma release assays, either a QFT or a T-spot. The TST has cross-reactivity with BCG, and so it's presumable that a positive TST could be related to BCG. Although I always caution people in clinical practice that if you have somebody with an exposure or other risk factor, you really need to think before you write it off to BCG. But the antigens tested for by the interferon gamma release assays, the QFT or the T-spot, are separate than the ones related to BCG. And so a positive QFT cannot be related to, or cannot be due to BCG. And so what you want to do in that situation is consider in engaging with either your local health department if you're not with the local health department, or potentially engaging with local and state health departments, maybe they can help you with the next steps there. But those providers may be considering a chest X-ray and considering asking about TB symptoms, and getting a good physical exam looking for other clinical signs of TB disease would be indicated. So, so exactly right. Good question, and good to be inquisitive about that response in that particular clinical scenario.
That's really aggravating. I wonder whether some communication directly to those PCPs would be possible to educate them that you don't have that cross-reactivity between BCG and the quantiferon test, or even when you send the referral, maybe including in that some education material for the PCP. But yeah, I would agree. I would talk with your state TB program. I'm sorry, I don't know where you're located, to see whether they have a medical consultant perhaps who could do some of that outreach. It sounds like it's a good opportunity to educate the community. And then we had another couple questions. Oh, we are definitely going to talk about definition of a tuberculosis outbreak, so we'll get to that. And then there was also a question about children in a child care setting and a threshold.
Is there an exposure time and intensity threshold that can be used for vulnerable contacts, including children age 5, and I'm assuming age 5 and under, and in daycare? And the short answer is no. But I want to sort of talk about where, kind of why. So the short answer is no, because there's two sort of factors that you want to sort of consider, and you're putting them both here, and this is a very good question. So first is exposure time to an infectious case. And the second is whether or not the contact has any of a number of conditions or demographic factors associated with increased risk of progression to TB disease. Yeah. So you have that one in the children under age 5. And so what we've done in the CDC, what CDC does in its guidelines around contacts, and what many state health departments do, is we convert a continuous risk. So people who are exposed for every day for 6 months, or living in a household with somebody, are at lots of risk. People who are exposed for 15 seconds are probably at trivial risk. So we've sort of put that into different boxes about, here's high risk, more than 8 hours, here's medium risk, and here's low risk. But what it really is a continuous variable. It's really a continuous
Don't get hung up on the 8-hour thing. Yeah.
So kind of what one of the things that we've done in outbreaks is we haven't given necessarily people, we haven't given a yes, test these people, no, don't test these people. We've tried to use administrative records to look back and quantify those exposure times and give a list of people by those exposure times. And so the people who are 15 seconds, they, if it requires a lot of resources to find them, they would be at the back of the line, versus the people who are household contacts and people with lots of exposure, they're at the head of the line. And so, no, you can't say that the people who had 15 seconds of exposure are not at risk. But really, if they really had 15 seconds of exposure, you need to sort of think about, did they really have 15 seconds of exposure? But no. So the short answer is no, but it's a no, but there are things you can do to prioritize. And that's really what the threshold is about, is where are you going to use your resources for diagnosing and treating LTBI and disease. And those resources are going to be better used with people with those longer exposure thresholds. And, you know, until public, we're still waiting for the unlimited resources here at CDC. But in the absence of unlimited resources, we totally agree with focusing on those people in the situation you're talking about, with those longer exposure durations, and then getting to the people with the really short exposure durations after that.
It's always difficult in a group setting, like a daycare or childcare setting, often what ends up happening is that everybody is evaluated, just to play it safe, but it's difficult on resources, yeah. And then what exam would you recommend before starting a new job? I think I would prefer we defer that to your, I'm sorry, I keep saying your state health department TB program. In many parts of the country, there are still requirements for TB screening, but that's very state specific. And in some situations, occupation specific. And yes, we're definitely planning to get these slides available. And oh, Nebraska. Yes, you did a wonderful job with that daycare. I was amazed at how well you organized the logistics of that daycare contact investigation last year. So actually, I don't want to throw Reed a lot of extra work, but I would definitely recommend reaching out to the Nebraska TV program, or it sounds like Omaha is on the line specifically. If you are in a situation where you do have to screen a lot of children, and how they handled the media inquiries, how they handled the logistics of getting all those kids screened without creating a lot of alarm was quite impressive.
And I see that, if I may, Anil, you have your hand up? You can unmute.
Oh, yeah.
Yes, I do. Thank you. Let's see. So, the question I have, I'm the director for disease surveillance and control for Clark County here in Las Vegas. The question I have, and I think many on this call may also be thinking of it, is recently the National TB Coalition of America released its guidelines regarding the RIR, right? So you provide a ride for individuals for 2 weeks and you remove them from isolation. What do you guys think of it? And who in the country? I know there's few people piloting it, but I do want to do that in Vegas, but not having 3 negative smears is worrisome because I'm from the old school and it's troubling. So any guidance, advice, recommendations?
So actually, one of the things at CDC is we're gonna stay tuned. We're gonna have a more formal, some more formal information out there, because the Advisory Committee for Elimination of TB, they've asked us to basically study the question you're asking. And so there's a group in the division that's more formally doing that, and stay tuned. But a couple of quick thoughts. One of the things about that guidance is you're going to want to make sure that it applies to the setting you're considering applies to you. So I fielded a number of questions about people who were in talking about that guidance, but the person lived in a congregate setting.
Yeah.
And so those aren't the kind of places I want. Want to make sure that people aren't considering that for in those types of situations. But I do think the guidelines address a really important issue. Is there's this tension between when we put patients on isolation, we are really disrupting their lives, disrupting their ability to participate in the economy, disrupting their families and things like that. And so we need to do that if we want to stop TB transmission and prevent TB-associated morbidity. But there's also evidence that shows that the therapies we're using and in the context of the right adherence really do render patients less infectious very, very quickly.
Yeah.
And so I also trained under someone who's very traditional, and sort of it was in the 2 weeks, is in the 2 weeks model. And that was sort of how that used to be weighed. NTCA and this group has proposed a new way to look at it, and we'll see. And there's a group at the agency who is working through that under charge by ASET, and stay tuned for their results.
Thank you.
For those of you new to TB, ACET is the acronym for the Advisory Council for the Elimination of Tuberculosis. I think we're caught up on the questions, so let's go to the next slide.
Yeah, thanks for participation.
This is great.
So now I want to introduce some terminology. And so you'll see the diagram on the left side that depicts a contact investigation, looking at in the center. At the center of that is a patient with infectious TB, and the people in the green are the contacts. But when you have an outbreak, you have more cases, and you have contacts around each of those patients. But some of those contacts are contacts to multiple cases, and some of the and so it all gets to be very lots of arrows and very complicated. But conceptually, an outbreak investigation is just several overlapping contact investigations. But the arrows can quickly become overwhelming and very challenging. So what is not part of an outbreak definition? So the number of cases, because even for some low incidence jurisdictions, a cluster of 2 cases would constitute an outbreak. Whereas for some larger jurisdictions with a higher incidence of TB, 2 cases would not constitute above what they'd expect. So recognizing that, our usual definition of a TB outbreak includes more cases than expected within a geographic area or population during a particular time period, and evidence of recent transmission of Mycobacterium tuberculosis among the cases. And that sort of criteria is usually met based on epilinks, so identifying patients who are exposed to each other, ideally with those infectious periods considered, combined with genotyping data. And as we alluded, epilinks among persons with TB disease, they can be patients who named each other as contacts, and also can be people who shared airspace at the same location during one person's infectious period, such as in a workplace, a bar, or a shelter. And these shared airspace, I want to focus on those for just a second, because those actually can be really, really helpful in those congregate setting situations. So where patients can't or won't name people that they were around, sometimes using administrative records can be used to identify people at risk for TB disease. And even though, you're probably thinking this is a lot of work for our health department. It can be really challenging to do, and we've got a lot of other things to do. But what that can do is it can help you sort of identify the people exposed, and it can help you later on when you're sort of analyzing the data to determine whether the people that you caught, people you captured in a screening event, for example, were actually people who you thought were to be at risk. And there's we'll get to that later, but if there's issues with that, there's people who can help you with doing that, so that you can continue to do all of the work that you all do very, very well in TB control. Sometimes epilinks are not as evident, and this is also a common theme of outbreaks. They're in the same social circle, but do not identify one another by name. There's 2 kind of situations where that can happen. The first is where they're in the same social circle. They probably would want to identify each other by name, but they know each other as Slim. And so it can be really challenging to identify who Slim was based on the traditional resources available. And so sometimes there's an area with an outreach worker who knows who Slim is. But if that's not the case, that can be very challenging. The other situation that we have, and this is, and these are both situations that are not sort of issues with the health department. They're just issues inherent to contact investigations and the most challenging contact investigations, and therefore outbreaks. So the other situation is where they're in the same social circle. There's an element to that social circle that they don't want specifically the health department and probably law enforcement to know about, such as using substances or other illegal activity. And so that can also be an issue. And actually, I thought of one more. Stigma can also be very, very powerful. And it can result in people not wanting to talk about who they were exposed to because of some risk that they will somehow be outed. And that can be really, really, really challenging. But we've seen health departments really establish relationships with people in that situation, and those relationships have often gotten better over time, and people have started disclosing contacts, but it certainly is a barrier to those prompt contact investigations that we discussed. And then there's places where you can identify that they spent time at the same place, but not clear whether they overlapped. And so it can be hard to figure out what to do with those, but if you can say that these aren't random patients, right? That can tell you that there's some connection between these people. You're not sure it's a transmission link, but it can let you know that you're probably in the right ballpark as far as the investigation and in the right social circle. And sort of when I think about epilinks in general, a quote that one of my mentors used to tell us, and I can't remember who originally said it, but TB is a social disease with some medical complications. And so if you're getting to the right social circles, and you can get to the medicines and the treatments to those social circles, that's TB control and TB prevention.
Developing those relationships. And sometimes it happens on the DOT side, you know, after they've been interacting with the health department for a number of weeks.
So now genotyping, which can really help us, especially in situations where those epilinks are proving elusive. So genotyping has to do with analyses of the genetic pattern of the strain of tuberculosis. And it's a laboratory-based approach that analyzes that DNA. And specific sections of that genome help distinguish different strains.
Sorry.
And so public health laboratories in the United States routinely obtain whole genome multi-locus sequence typing results for culture-positive cases. And what that means is basically once an isolate from a patient is shipped off to the state health laboratory, those state health laboratories can generally send it to a contract laboratory, and we can get DNA sequencing from all culture confirmed cases, or virtually all culture confirmed cases. And so when those strains match, we can say that there could be, these people could be in the same chain of transmission. However, most cases are MTBC unique, means that they're genetically distant from all other genotyped cases. And that often occurs in the case of, in cases where TB is thought to be reactivation from disease or infections required in the remote past. Okay.
So now we're going to shift into outbreak detection, and we're going to use some case studies to talk through these concepts. So if you don't mind doing this mental exercise with us, where you just think through whether you would consider this to be an outbreak, and please use the chat. So whatever your usual jurisdiction is like, think about how many cases of TB maybe you reported last year and the year before. Imagine you're in a county that maybe normally has 15 cases or so a year. But so far in 2024, you're up to 25 cases. And unfortunately, we know that a lot of you are dealing with surges in cases, but is this actually an outbreak? What other information do you need to decide whether this extra 10 or so cases is a sign that you're experiencing an outbreak? And feel free to use the chat to throw some ideas in. Well, and nobody is chatting, so let's just go on to an example. Oh, here we go. Here we go. Yes, you're looking for epilinks, evidence of transmission. Yep. It wouldn't be an outbreak necessarily. Yeah, how close in time, epilinks, when they arrived in the United States. Okay, great. Great. A lot of our case studies are going to hit on these concepts. So go ahead, Jonathan, talk us through scenario 1.
So scenario A, 7 of 25 people were experiencing homelessness and had recently spent time in a local jail. And 4 of those 7 culture positive TB and 4 of those 7 had culture positive TB and share a matching genotype, not seen in any other jurisdictions. What do y'all think about scenario A? Would you be concerned about an outbreak? I'm hearing a yes.
Yeah. Yeah. I think this one's pretty much a slam dunk, right? They've got the epi characteristics as well as the genotyping. Oh boy, yeah.
And so you'd really want to sort of start your contact investigation resources, coordinate those contact investigations, and think about where do you need to intervene, and talk to your homeless facility about their infection prevention procedures. Engage with your local jail partners and see if there's opportunities to shore up the infection prevention procedures there. But absolutely, outbreak response is good here.
And I think the most important thing is not to feel like this is a situation you should handle on your own. This is definitely when you talk with your state counterparts, and potentially they might decide to call us. We'd be happy to give some consultation as well. This can get really messy and difficult, and it's not something you would be able to probably handle with your typical approaches. All right, scenario B, and some of you alluded to this in the chat. What if a lot of these 25 cases you've had so far this year are people who've recently arrived and they've come from countries where there's a lot more TB? And even though they're not all culture positive, those that are culture confirmed, you're seeing a ton of different MLS type results, a lot of MTBC unique or cases that have a genotype pattern that don't match anybody else in the state. And Susan saying no. Yes, it's still a lot of resources, right? They might all need contact investigations, but it's not an outbreak. And this is sometimes harder to explain to people who are used to other infectious diseases where it's all about numbers being higher than what you'd expect. But it's not a tuberculosis outbreak. There's no evidence of transmission among them. All right.
But you're certainly right. Those of you who are saying that there's certainly resource needs.
Yeah.
Both in contact investigations, DOT, routine TB control, and depending on when the patients are when they're diagnosed relative to other interventions, maybe there's an opportunity in this particular community to emphasize diagnosis of treatment of latent TB infection. So certainly a public health response, but the public health responses between scenario A and B that are likely to get the most bang for your buck are different. And so it really is important to think about situations as more like scenario A or more like scenario B, recognizing that, you know, we've kind of dichotomized this and made this pretty obvious. We know it's not like that in real communities.
Yeah, within scenario B, you might have some smaller clusters, right? Hopefully, though, with just household transmission. All right, scenario C, Jonathan.
So a new clinician in your jurisdiction is more apt than predecessors to diagnose TB in children. Because TB in children is often a clinical or provider diagnosis, no genotyping results are available. What do you think about this as an outbreak?
This might be it depends if that might be why they're pausing. Yeah.
Need more info, find adults, track history, need more information. Possibly.
Yeah. Yeah, if it's a bunch of interconnected households, you definitely need to be thinking possible outbreak situation. But if it's a bunch of kids from all over the county with very different stories, thank you, new pediatrician for thinking TB. Yeah. And of course, another conversation to have is actually obtaining cultures on the children with gastric aspirates or something else to help out. All right, let's go on to scenario D. All right. Some of you on this call have so much experience with this, like Katie Steinbach could give you a whole wonderful presentation. But what if you suddenly unexpectedly get genotyping results back and cases that you were not expecting to be connected based on your original interviews actually have a matching genotype? But one curious thing about this, is that they all went to the same hospital and all maybe had a bronchoscopy within a few days of each other. Yeah, exactly. It's time to call the lab to talk through whether you could have a cross-contamination or mislabeling issue. I'll just say one thing, and that is it doesn't necessarily mean that they don't all have TB. They could legitimately all have TB, but it was just that particular specimen got cross-contaminated. So you don't necessarily need to take people off of treatment, but yeah, this is where you definitely want to send more specimens if you have them, and try to get to the bottom of the story, because in some cases, people can come off of treatment, they don't have tuberculosis. Yeah, lots of good stuff here. Now, one key thing, and you'll see this in module 9 of the safe self-study modules, if you're doing a contact investigation, it's not unusual to find one secondary TB case maybe in the household, that 1% Jonathan was talking about. But if you're finding more than one active TB case among contacts, or a bunch of contacts with latent TB, especially if you're seeing children who presumably were recently infected because of their age, or adults whose TSTs or QFTs or T-spots, whatever you do, were negative on the first round and now they're turning positive, that is evidence of recent transmission. And that's a good time to start thinking, wow, we might have an outbreak on our hands. And the other situation, and this is where the genotyping can really come in handy, is sometimes TB will be diagnosed in somebody 6-12 months after your contact investigation. You didn't think that person was a contact, but when the genotype result comes back, it's a match. That could be another clue. Let's go back and try to figure out the connection between these two. And if this was a missed contact, there might be other missed contacts. You might have an outbreak situation. And yes, that's so true, Katie. Sometimes someone's already been on treatment for a few months by the time these cross-contamination situations are sorted out. But it's not uncommon for cross-contamination issues, that scenario D. So it's good to don't assume there's got to be an epi-link between people just because there's a match. It might be a lab mix-up. And then moving on to another scenario. All right, Jonathan.
So scenario E, a cafeteria worker in a local school gets diagnosed with TB. A decision is made to test all the children at the staff at the school. No additional TB cases identified, just a small number of non-US born adults with latent TB infection. What do you think about this one?
Susan.
I'm hearing a no.
No, not an outbreak. Yeah. But can you convince the school principal that this is not an outbreak, or the local TV station, or the parents? It's a really tricky communication scenario, but I've never seen a contact investigation described in a school in the news without someone calling it an outbreak. It's definitely a situation where you need to do a lot of education if possible to prevent alarm.
Yeah, these scenarios are really hard, and I know that we get consulted about these cases in schools, and I know that health departments work really hard, test a large number of contacts, and sometimes this is done to sort of improve relationships with school officials, or to improve relationships with parents, even when many of the people would not fit the traditional contact definitions. We recognize that those are really challenging communications and public relations scenarios, and are happy to help state health departments with those when we can, but certainly recognize that difficulty. And many of you are pointing out that people who are non-US born have a higher prevalence of positive tests for TB infection and latent TB. And so this is less likely to be an outbreak.
And then our last scenario on the detection side, this actually happened. This was 2005, it's been a minute, but we had a situation where there's a casino where 3 of the third shift workers were all diagnosed with TB disease within a few weeks of one another. And then one of the taxi drivers who would drive one of them back and forth every day to her apartment also had TB disease. And so we were definitely, well, I went with one of my coworkers to help the health department with this outbreak. But while we were there, we started to get the genotype results and they were all different. So in fact, it was 4 different contact investigations. There was no transmission among them. It was just a crazy coincidence. And yeah, we can talk another day about third shift work, long hours without exposure to sunlight, possibly playing into it, but it was not an outbreak. So you can see we use the genotyping results a lot to help rule out outbreak situations. And now going to try to move quickly since we've only got a few more minutes through the outbreak response. But honestly, the most important thing is for y'all to be able to recognize when you might have an outbreak and then talk with your state TB program about it, and not necessarily feel that you have to be able to mount a response on your own at the local level, because even the most well-resourced health departments in the country need help when they have outbreaks. So in terms of outbreak response, you can definitely read more about this in Module 9. You generally need to get a team together that involves people who maybe don't usually do TB, to cross-train to help out. One of the key things we've learned over the years is you need to have one point person to be the coordinator, who can help with all of the day-to-day task assignments, priorities, communications to upper level. But basically the key message here is to ask for help. And then you can go through the self-study module if you're interested to see what our general steps are. But one of the key points, once you've determined you actually have an outbreak, is to create an outbreak case definition. And we often use the genotyping results to help rule people in or out. And the way we manage cases that don't have genotyping results, maybe they were just recently diagnosed, so it's still cooking, or it's a kid, is that's where we rely on EpiLinks. And there was a question about the casino scenario. Does that mean if people are not a genotype match, even with EpiLinks, it's not considered an outbreak? Exactly. Yes, exactly. It's just really bad coincidence, bad timing, but there is no evidence of transmission among people if their genotypes are considerably different.
And this can be a challenge for those of you who work in less populous areas. For example, you can identify epilinks between people. Maybe there's only there was a recent situation where there might have been only one social club, and everybody goes to the social club,
or one grocery store in that town. Yeah, exactly. Everyone's epi-linked somehow because it's a small community. Yeah.
But those epilinks might not have resulted in transmission of M. tuberculosis, and so so that's where genotyping can really help. And actually, genotyping is really helpful when it excludes transmission, because those are the situations where you can divert those resources towards investigating transmission and outbreaks. You can divert them away from those situations where the genotyping does not support the patients are in the same chain of transmission.
And then one key concept here is because most of your data management systems and health departments for contact investigations have this assumption that there's one case and then a list of contacts, and here's what their disposition, their final status is. And then here's a new case and their list of contacts. There is often a situation in an outbreak where you've had people who've been re-exposed, they might need to be reevaluated. And you don't want to find yourself rewriting the same contact name on 10 different case investigations. To save time, to save resources, this is definitely the time to involve an epidemiologist. And again, this is where we can often help provide consultation, especially if the TB program in your health department hasn't always had an epi on staff or worked closely with the epidemiologists. I hate that we haven't had more time, but we'll be sharing the full set of slides. And for sure, there's nothing here that is not part of, oh, I wrote number 39. I was trying to jump to slide 39. We haven't talked about anything here that is not part of the self-study modules. Yeah, the whole duration of time for exposure. This is where we'd love to provide more specific consultation for your specific situation. I really hate that the 2005 MWR that gave contact investigation guidelines used a EG, for example, 8 hours, and then everybody saw that EG and interpreted it as an IE, that is 8 hours, which is why I jumped on your 8-hour example. There's nothing magical about 8 hours. It reminds me of the early COVID days when we were all about 6 feet, 15 minutes. There's nothing magical about these definitions. Yeah. It's better to talk through it and figure out what makes sense for y'all.
And for congregate settings, those are going to be, depending on the type of congregate setting,
the airflow, there's all kinds of
there
things.
could be more intense exposure. And in some congregate settings, there's a higher prevalence of progression to TB disease. And so you may want to have a lower threshold in those particular scenarios, but absolutely agree that you'll have to consider the, so again, you'll have to consider the exposure duration, but you'll also have to consider the prevalence of conditions that increase risk for progression to TB disease when making a good decision. And then the other element that I typically recommend is reassessing after you start the contact investigation. If you're getting, so for example, say there's 100 contacts and you decide to start with 50 of them, and of those 50, 45 are positive, then unless you're able to sort of identify why those 40 should be positive and not the other, then you may need to sort of think about a different, expanding that strategy. Because after exposure, you'd expect 20 to 30% of people to have positive tests for infection.
At most, yeah.
At most, even in a situation with non-US born people. So a number like 40% would be extraordinarily high. Additionally, if you're identifying and diagnosing TB cases at a rate that's more than 1%, also need to raise your eyebrow. And so, hate to answer your question with a non-answer, but that probably requires a bit more consultation, a bit more consideration of the, as Miriam said, of the individual circumstances to make a recommendation. And also two experts may give you
Have
two
different opinions, yeah.
And there's probably a spectrum of reasonableness.
Yeah, as you were talking, I just thought contact investigations are thought of as a more linear process. Okay, you identify the case, you interview them, figure out the contacts, test them, and then test them again 8 weeks later, and you're done. Outbreak investigations, it's much more iterative. That's why you need a team. You can talk through some of these decisions. As you get new information, you revisit the decisions you made to make sure you're still comfortable with them. But anyway, we are definitely here as a resource to you. Your state TB program knows how to get in touch with us if you are not at the state level yourself. If you're ever in a situation where you think you might have an outbreak, I guess the key message is ask for help, early on. Don't wait for it to get more complicated. We do all kinds of phone, email consultation to help people talk through a situation, just to have an extra set of eyes on it. So Shweta, do you want to take it from here to close us out? I'm very sorry we went over a little.
Yeah, no problem. Thank you so much for doing this, and I'm loving all the discussions in the chat, and we're very grateful for your time. And what a way to close our TV 101 series. Thank you everybody for joining, and we really hope to have the slides and the recording up on our website as soon as we can. Next week we have our clinical TB intensive, so it's a little hard for us to process these, but definitely the following week, all these will be up on our website. Okay, well,
Thank you all so much. We really appreciate all of your participation.
Yeah, it's great.
It's always, thank you.
well, thank you all, and we all hope you have a great weekend. Thanks, everybody.